Oh, hello, I'm Jose Miguel Bueno, I'm from Spain, GP. We are 5, Australia, Taiwan, UK, the Netherlands and Spain. Regarding the first question, we think that the services should be accessible, so should be provided after hours. Also accessible means that if you go to be at clinic for a week, you should have a locum. That depends on how the health services in your country. So, for example, a national health service, but in countries where you are private, you work for private, then you should have an insurance that allows you to just be at the hospital earning money, because otherwise you become marginal in the end. Then it should be confidential. We should detect the pathology before it happens. Independent. You should be cared by a doctor, respected, but not with whom you have a relation, and there should be an advocate of you. That is what we think about it. But also depends very much on your country. There are countries in which you got a contract with the National Health Service, or you just work for private, and that is very different from countries where most of the doctors are just civil servants employed by the government.
Can I just ask you to expand on the point of access? Was the only point that came up under access 24-hour access, or were there other issues that came up under access?
You should have accessibility. You have several sides that should be just to be able to attend it, but also accessibility is also money. If you've got to be, you need to be funded. You should have an insurance. I don't know how it works in Spain. When we've got, I'm also the General Secretary of the General Medical Council in my region, so those who are in Barcelona, they get a sick leave and we pay them the full treatment. No, 95% of the treatment. We've got 2 or 3 colleagues who are now in Barcelona, and that's very expensive, and that is also accessibility. So, and also if you also confidence, also accessibility. If you are not, if you don't rely on the system, on the person who is in charge of you, you won't go there.
Thank you very much.
We're quite a small group, and as soon as we've set up, 2 left straight away, so not to be sure what that says about us. 2 Irish and 1 Norwegian, 1 American. We actually were more free-flowing in our discussions insofar as we didn't stick to the agenda. So I'm going to try and get what we said into this. Specific services, the first thing that came up was confidentiality. We all felt that we actually expected and demanded a level of confidentiality that most other patients wouldn't have expected. We also wanted to have doctors who had special skills and experiences. We called it the elephant in the room. We felt as doctors we would manipulate any consultation to our advantage. So we felt that we were going to, the consultation was quite different. We felt it was quite important that at the very start of any meeting with a doctor, we should actually just state that what's going on in the consultation. The next thing we said also was that we did feel that we needed consultants, or not consultants, but certainly people with experience in substance abuse that would be aware of how we could manipulate the system as well. As part, the one thing that came out very strongly in our group was that we felt it was very important to access the system in a normal way. We felt that it was, we have people, we have Norwegian and an American who actually book appointments, normally go into a normal waiting room, and they play the role of the patient the minute they arrive into it. While certainly my experience and the Irish experience is that we tend to see our colleagues after hours and immediately we're manipulating the consultation a bit more. And that's all we got to at that point.
Very good. We again have a big group. We got into this so heavily and so quickly we didn't even find out where we were from. But looking around, I think we won 2 from Canada, or no, 1 from the US, that's correct. Australia, Canada, Belgium, Slovenia, Denmark, and 2 from Ireland. But the other
Can't be too Irish.
yes, exactly. The other thing is we had a lot of thunder that's just been stolen because they really have the points seem much the same. I suppose the thing we did get very heated into was the issue about whether or not doctors needed to be treated differently or whether they were special kinds of patients. And it was a toing and froing in the sense that we felt that they should be recipients of the normal service and they should be treated like other patients. But then we realised that, again, like you, that doctors will manipulate things and they will not present in the ordinary way, and therefore, in fact, one has to have an awareness of, if you like, the different behaviour of doctors in order to treat them properly as other patients. So, again, as our Danish colleague said, in an ideal world, which I thought we were supposed to be living in for this purpose, then doctors wouldn't behave like this, so we could treat them like other patients. But because we don't live in an ideal world and doctors are manipulative and clever and so forth, we actually have to provide something that recognises that. One point we did have, I think, was unique. Oh, good, we have a unique point, which is about medical education. We felt that this is something from the early days that students need to be educated to their vulnerability as patients and the potential to be a patient, and that when they are a patient, they should behave as a patient and forget they're a doctor. We had that point about special rules. We also touched very much on the issue of confidentiality. We felt that, and we did an interesting discussion about that in the sense we initially felt that that applied particularly to mental health problems, but in fact it also extends to physical health problems, and certainly there was an issue that I mentioned in the group that sometimes physical health is seen as not requiring the same confidentiality, but it does for the people whose mental details are leaked all over the medical school, an example I had. We touched a little bit on the impact of geography on all of this too, that it kind of is easier to provide these kind of services and confidentiality and so on in a large or a more anonymous medical community, but in a small, more intimate medical community like we have in Ireland, it still can be very difficult to get sufficient distance or separation. We thought that Villasan was a great idea, and we also felt that with an interesting example is, the Villasan was a good idea. Also a good idea was to extend these services to families of doctors and not just the doctor, because they also kind of have special needs and have difficulties accessing ordinary medical care.
We were here from Australia, Malaysia, Curacao, Croatia, Portugal and Israel, so we had a lot of countries. We don't have many new things, but we spoke a little bit about the necessity of ongoing regular support or maybe some supervision for doctors for prevention of getting into all those depressions, burnout and so on. The training of doctors, again, we want to emphasize it very much. It would include maybe even having role models for them, not just theoretical training, to see that when you're sick, what do you do when you're a doctor? Having different hours, for example, at the end of the consultation, because most of us were in favor of being in the regular treatment services. But we stress the necessity to give doctors a choice, like you said in your presentation also, confidentiality, and we spoke about occupational health, that maybe it should be mandatory, and this is something to discuss further, of course. We stressed also the issue of extending the care to doctors' families, like the last group. Because doctors tend to do shortcuts, especially to treat specialists in other fields who are not GPs, and they come to a GP and they think they know much better, and it's very, very tough and also dangerous, I think. For the second, we're doing the second question too? Yeah. Okay. We thought that it should be not the same for basic health needs, in which we believe that we need to be in a regular system and to get normal care according to the standards. But when we have a specialized problem that maybe arose from our profession and could be related to the employer's, to the relationship between the doctor and the employer, then we should have a specialized service. Although it was stressed that every employer should have a program for employees' health.
I think most of it's been covered. We did talk about the fact that we value the special system that was suggested from Norway for issues to do with doctors' health, and not a special system for general health, but doctors who are particularly aware of how and capable of how to treat doctors. So I guess it was all special. It was doctors who are good at treating doctors, to be available at least to treat doctors, plus the special system for mental health. And then we talked about isolated practitioners and how they might not feel comfortable going to the other local doctor in town or the doctor in the next town, or sitting in the waiting room with lots of patients all guessing what's the matter with them or whatever. And that we might need to set up some special service for them so that when they're coming to the city or a larger town, so they can phone ahead, book in, get a long appointment and get everything arranged in as quick a time as possible. So the doctors who really are lacking confidential approach could get it. And then one of our members raised the issue that for doctors it might be quite a, what do you call it, affect our sense of who we are, being patients, because we think of ourselves as doctors, and that's probably true of all of us to some extent, and there are identity issues for us in that, and we might actually need help working through it. Though if we felt confident in the system and we went ahead and it worked for us, we'd probably be more confident next time, even if we did have some identity issues, because we were happy with the quality of the care. But if you go and you get care that you're not happy with, and you've got no one to talk about it with, all those issues are compounded and you might be less likely to seek care next time. And then somebody raised the issue about what if the doctor's incompetent, and they won't do anything about it. And we didn't really come to a solution on that one, but we acknowledge that's an important issue. That's not necessarily fully incompetent, but practicing, not the treating doctor, the patient doctor. What if the patient doctor has issues that make you think that they are not competent to go back to their field of expertise, particularly if they're either in denial or lacking